Today, class, we're going to talk about the care plan. So we talked about this back in Chapter 8 when we were looking at health team communications, and we talked about how to develop a plan of care. Now, the plan of care is actually developed by the nurse, but as a CNA, we are going to be helping assist with this plan of care. We're going to be helping with the interventions. We're going to be giving them feedback of how they're doing for their evaluations. And so we're going to talk a little bit about just how a plan of care would be developed. Now, we had talked back in Chapter 8 about our acronym ADPIE. And ADPIE, the A stands for assessment. So the nurse would do an assessment of the patient and determine what type of nursing problems does that person have. And they would develop a nursing diagnosis from that. It's not the medical diagnosis. It's the nursing problems the person has because of their medical diagnosis. And there is actually a little chart in box 8-4, sample nursing diagnoses. And when you move on for your nursing career, for those of you that decide to go on for LVN, RN, you'll learn that there's entire textbooks written about what we call NANDA, the North American Nursing Diagnosis Association. And they have lots and lots of different nursing problems, okay, that we could address. So our A is assessment, our D is nursing diagnosis, so diagnosis. The P stands for the plan. We're going to develop a plan of care. So that nurse is going to determine what are those nursing problems, what plan of care do I need to do to take care of those problems. So we need a goal. What is our goal going to be for that nursing problem? And then we're going to look at what interventions, so our I is what interventions can we do to implement. Well, actually, the I is actually stands for implementation, but it's what, so our part of our plan is developing those interventions as well that we can implement. So as a CNA, our biggest role in this whole plan is the helping with the implementation. Now, it's not that the plan of care has to be completely all done by a CNA. It doesn't. The RN, the LVN, physical therapy, dietitians, everybody in that health team is really going to get involved in this. But as a CNA, we are going to be really helping the most with that implementation of the plan of care. And then the E stands for evaluation. It needs to be looked at. Is our plan working? Okay, is our plan working, or do we need to tweak it? Do we need to do something different to make this happen? So I thought I would start, since we've been talking in this class about dementia quite a bit. I thought I would just kind of show you just a real quick, simple little plan for the care plan for dementia. Now, dementia would be the medical diagnosis, not the nursing diagnosis. It would be the medical diagnosis. So the nurse would assess that person and say, what kind of problems does that person have because of that dementia? So one of the problems I put was a self-care deficit. You'll find that a lot of patients with dementia, they kind of forget how to take care of themselves. And so if my nursing diagnosis or my nursing problem is a self-care deficit, and that's related to the dementia, to the loss of cognitive function, my goal would need to be something to do that. What would my goal, if they have a self-care deficit, my goal might be that they might be able to complete activities of daily living with minimal assistance, say in 2 months. Or maybe that it's that they won't be resistant to care to do activities of daily living in the next month. I mean, depending on what level they're at is going to determine what my goal might be because of that self-care deficit. That self-care deficit, my goal would have to be reasonable. It would have to be realistic. It would have to be measurable. How am I going to be able to tell if it can actually happen? And it needs to be dated as to when we think it can take place. And that may be 3 days, it might be 3 weeks, it might be 3 months, okay? But when do we think what we're going to do for this person that it might actually be achievable, that they could reach that goal we set for them? So then I would have to develop interventions. What would the plan be? What could I do to help reach that goal for that nursing problem? So for the nursing interventions, one of the things I put was follow routines as much as possible to the residents' normal behaviors. You're going to find that patients that have loss of cognitive function do best if they have set routines. So why could we not find out their routine from what they had at home? If they're early morning risers, if they like to get their care first thing in the morning. Some people like to do their bathing in the evening before they go back to bed. So we would find out what's a normal routine for them. And we could try to tailor our care to kind of follow what their normal routines have been for most of their life. It will help them. It will make it a little bit easier for them to be able to get through that step. We would Another intervention I put is we could use simple step-by-step instructions or pictures when communicating. So giving long, complicated, I need you to take your bath, get dressed, and brush your teeth. That doesn't sound like much, but if you have dementia and you don't even really remember all those steps, it's okay. We need to take a bath. We're going to wash our face. Then we're going to wash under our arms. So, yeah, I mean, we have to break it down into more simplistic steps. And trying to give them a lot of complicated instructions or long instructions are not going to be well received. So doing real quick, simple step-by-step instructions, or even just showing them a picture of taking a bath or showing a picture of getting dressed, sometimes their brain will sync to that a little bit better. I put allow the resident to perform as much a task as possible. So again, if you remember one of the videos we showed you in the first week of that hand under hand technique of putting the brush in their hand and kind of holding your hand over it and just starting to bring it up to where it goes. And a lot of times then they'll just automatically start doing it. So allowing the resident to perform as much for themselves. I know it's quicker and it's easier just to do things sometimes for people, but that's not what they need. That's not what's going to help them. And the other thing we can do for an intervention is we could have the care done in smaller increments so this resident doesn't get overwhelmed. So instead of trying to bathe them all at once or give them have them brush their teeth and get dressed and fix their hair and do everything at one time, maybe in the morning when we go in there, especially like let's say they have incontinence issues, maybe we do peri-care and put a fresh brief on them. And then before breakfast, we give them a washcloth and we help them wash their face and their hands. And then maybe after they eat, we can help them get their underarms and their back done and put a clean shirt on them. Well, you know what? We just did a partial bath. Okay, I mean, it doesn't have to be done all at one time. We can break the care down in smaller increments so it doesn't overwhelm them or overtax them. You're going to find that sometimes patients with dementia just get overly stimulated and then they have aggressive or catastrophic behaviors because of it. So here's another potential problem I put wandering. So we know that wandering is a really common thing to happen with dementia patients. So wandering, our goal might be that the resident will have minimal episodes of wandering by 1 month. So what are some interventions? What are that plan of care that I can do that nursing care can help with to help achieve that? So one, we can maintain a safe environment, maybe including wrist alarms. So we've talked about with dementia patients, they can actually stay in locked facilities where you have to have a key to get in and get out of the facility if it only caters to dementia patients. But if you're in a regular nursing home and they cater to all types of different patients, they're not allowed to have them locked facilities. But what they can do is they can have wrist alarms on. So when they go through the door, it will sound off an alarm to let people know that a high risk, patient has gotten out of the facility, so we can hopefully guide them back in before they get lost. Encourage participation in planned activities. Get them involved in things that are going on at the facility to keep them from wandering, to keep their interest piqued, so they want to stay there. Assess residents' needs for feeding, for toileting. Sometimes they wander because maybe they're looking for the bathroom or, they're just confused of where they're at and they're trying to find their way home. So sometimes, they're wandering because they need something. They just don't know where to find it at. Another potential problem I put was risk for injury. And so their goal might be that they will be free from injury while at the facility. Now, that would be a fabulous goal, not always realistic. You guys, it's not going to be practical that we can always keep people 100% free from accidents and injury, no matter how hard we try. But our goal is always to try to keep them injury-free as much as we possibly can without restricting their mobility. So how can I keep them free from injury? I can assess their environment and remove hazards. So if they have things that are potential trip hazards, things that are in their way, things that can make them get tangled up and stuff. Okay, I can always assess for those types of things. Hourly rounding. When you have a high-risk person who's a high-risk fall, high risk for injury in any way, making sure we're checking on them every hour, just peeking in, seeing how they're doing. And remember, when we do hourly rounding, when we talked about our safety chapter, the 3 P's of hourly rounding: potty, pain, position. Do you need to go to the bathroom while I'm here? Can I get you repositioned? Can I do anything to make you more comfortable? Are you having any pain? And I'll be back in about an hour to check on you. And when we check on them more frequently and we're meeting their needs more quickly, you'll find a lot of times that they won't wander quite as much. Proper lighting sometimes can help as well to keep a risk from injury. So, if you have poor lighting, you get a lot more shadows. And especially with our elderly population, if they don't see quite as well, that can always, of course, be a detriment. So I just picked 3 quick, simple, little, easy potential problems. But again, when we have a nursing diagnosis, it's a nursing problem, not the medical diagnosis. It's nursing problems that the nursing team or the healthcare team can take care of. We have to have a goal, and that goal has to be measurable, it has to be realistic, and it has to be dated as to when we think it can be accomplished by. And then we need interventions. What kind of things are we going to do to try to make that goal happen for them? And again, that is probably the biggest area as a CNA where we're going to fit into. Of course, we can, when we report back to the nurse, to let them know how things have gone, or if we got them involved in activities, or how they did with their care. They can help use that information for the evaluation process. And so when we reevaluate the plan of care, so every so often this plan of care is going to be reevaluated, and they're going to say, okay, we met this goal. This goal, we were able to achieve it. It's worked. So let's say if I go back to this first one, self-care deficit, let's say in 2 months that person's able to complete their activities of daily living now with minimal assistance. I would put down on the care plan that goal was met, that we don't have to keep working on it because we've taken care of it. But then I'm going to reassess that person and determine if there are other problems or other issues that person might have that maybe I need to start addressing. You guys, if you have a patient who has no nursing problems, they have no nursing problems, nothing that we need to take care of or help them achieve, then what are they doing there? Do they even need to be there? Because if a person's in a hospital or a person's in a nursing home, that means they have problems. Okay, that means there's something that we should be working on to help get them better, because our goal is always going to be to help them achieve the optimal level of function that we can. So if there's nothing we need to do for that person, they don't need to be there. Okay, really, it's probably time for them to go home and get discharged. So that's something to keep in mind. There's always problems. So this care planning, this ADPIE, assessment, nursing diagnosis, plan of care, implementation of that plan, and evaluation. It's just an ongoing cycle that we're always going to be readdressing, seeing if we can improve on our plan of care to make it better, or to make it more efficient, or to make it where it works better, taking off problems once they've been met, adding new problems as they happen. Okay, so it's an ongoing cycle throughout a person's entire care. Now, in a hospital setting, that plan of care is addressed about every 3 days. They will look at that plan of care and determine, what's going on with that person. And that plan of care has to be reviewed before that person goes home. Did we meet all their needs? And if not, do we need to arrange follow-up for when they go home? In a nursing home, again, some of these people live there, so our care plan isn't necessarily going to have to be addressed every 3 days. But it should be looked at. Usually they will look at the plans of care either weekly or at least monthly for really long-term patients, but usually weekly. They'll at least look at the plan of care, determine if it's still relevant. And then every 3 months, they do these care conferences in nursing homes. So the care conferences, the patients involved, the patient's family, nursing, social services, people really involved in their care. And the CNAs who you would think might also want to be invited to that usually aren't, but um, so they will have this plan of care with the patient, the family, and some of the key personnel, and they'll talk about here's what we've been doing for you. Here's what we've been trying to accomplish. What's working? Why isn't it working? Is there other things we can do for you? So depending on what the plan of care is and how well the person understands things. Now, if I have a patient that has dementia and they don't have cognitive function, obviously being involved in this plan of care might not be for them, but their family members. This is what we've been doing for your loved one. This is what's working. This isn't what's working. We're going to look at other things. And we want people to be involved in their plan of care. They need to have buy-in to make it work. And so having the family involved, the patient involved when possible, depending on the diagnosis, it's very important. So that's just kind of a nice quick overview of a basic care plan and how as a CNA we can help with it.